Thank you so much. This is why we have a team, right? So I'm going to go ahead and get us kicked off today. The first thing that we want to do before we start our conversation is to do a labor and land acknowledgement. So in line with the Council's values, we are working to more thoughtfully integrate land and labor acknowledgements into all of our forward-facing presentations and conversations. So we are focusing today on the land of the two council staff that are leading today's conversation, myself, Caitlin Sinovec, and Barbara, who are located in what is now Florida and Maryland. So we honor and acknowledge the original stewards of this occupied land. We stand on the unceded ancestral lands of the Seminole, whose ancestors still reside in Florida, and the Timucua, Miccosukee, Muskego, and Tokobega people, past and present, and honor with gratitude the land itself and the Seminole, Timucua, Miccosukee, Muskego, and Tokobega. We also honor and acknowledge the original stewards of this occupied land of Maryland. We stand on the unceded ancestral lands of the Conestoga, Susquehannock, and the Piscataway people, past and present, and honor with gratitude the land itself, the Conestoga, Susquehannock, and the Piscataway. And then we also acknowledge the labor of Black and African American people, ancestors and descendants, who recognize that the United States and global economies historically and currently rest on the ingenuity, cultural treasures, and stolen labor of African American and Black people throughout the diaspora. We honor the brilliance and humanity of all immigrant labor, including voluntary, involuntary, trafficked, forced, and undocumented peoples who contributed to the building of the country and continue to serve within our labor force. And we express our heartfelt gratitude for their independent contributions. By recognizing the land that was taken from first Americans, the forced labor that was provided by enslaved Africans and Black and Brown people, we strive to take steps forward to create a more equitable and just world for all of us. So starting that in our mind today, especially as we're talking about policy and advocacy, that really relates to justice. So I am going to go ahead now and turn it over to Barbara, who's going to lead us and begin our conversation today.
Great, thank you, Caitlin. Thanks everybody for being here. I think this is one of the discussions that we really need to have in our community is how we're integrating our service with our advocacy. And to that end, we really wanted to have a conversation to level set about, well, what do we even mean when we talk about advocacy? What do we mean when we say get involved in public policy? And I think that there's really important ways that we're advancing not just our programs, but really advancing the values and advancing the kind of community that we want to see through our advocacy. And so just want to take a few minutes, just kind of level set. For a number of you, this is old hat, but for some of you, this might be new. And so I always appreciate it when clinicians talk me through a little bit of medical things so that I better understand. And so this is just a way of sharing each other's world a little bit more. So when we talk about defining advocacy, really when we look at what does the term advocate mean in terms of a verb, it's an action. How are we writing or speaking in favor of or supporting or urging or arguing for something? How do we recommend something publicly? So we're specifically talking in a public context. So just gets us a little out of voicing opinions at your dining room table to your Uncle Fred during Thanksgiving, and more like, unless your Uncle Fred is your city councilman or your governor, in which case then of course it's public. So thinking through how and where we're having those conversations and with whom. Advocate, or as a person who writes or supports and participates in advocacy. And through the years, the council has come to a definition of advocacy whereby it's the educational process through which data, experiences, and insight are shared with those who craft public policy so that they may make more informed decisions. So a lot of times, particularly as nonprofit organizations, we tend to get a little squirrely about, oh, I can't do advocacy. Oh, I can't talk to my public officials. Absolutely wrong. Is 100% legal for nonprofit organizations not only to engage in advocacy, it's also legal for us to lobby. It's just that there are some federal restrictions on how much of our total budget we can use for that. But ultimately, it is our mission, our very mission, to be educating our policymakers about the realities of homelessness, to be to advancing not just the data, and we've done a lot, right now about outcome measures and how we demonstrate our effectiveness, but our storytelling, the experiences of the people who are in our programs, the experience of the people who are working in our programs. We have to have public policy that is more informed by the people that it's impacting. Nothing without us, nothing about us without us, right? And yet we can point to many public policies and policymakers that do not have an informed understanding of homelessness, do not have an informed understanding of what it means to be without a place to stay and be sick. We know what those policies look like. So how is it is absolutely our role to be filling that gap and making it so that they do at least are informed. Now, obviously, making the informed decisions can be a process that as well. So anyway, and also I just want to say at this particular time, it is our moral imperative to be a part of these discussions. Anyone who brings the values of human right to healthcare, anyone who brings the values of wanting to see a decent healthcare system that's able to address the needs of vulnerable people, we need those voices in our public policy system. And right now, I completely understand that in many communities, we've politicized so many things that it's often difficult to even have a rational, thoughtful conversation. But I would urge us that if we're not the ones at that table having that conversation, who is? So I put that there. If we can move on, I'm sorry, I'm getting on my soapbox. So let's move on. Let's talk also about how we translate the idea of individual advocacy, which is very natural for service providers, into policy advocacy and what that transition looks like. And so just appreciating the difference here between these different scenarios. So when you're getting a housing voucher for a client and you're working the phones and you're trying to find a unit and doing all of that for a client, that's individual client advocacy. That's a fundamental part of many people's jobs. When we start getting into getting more state funding for building more housing, how are we talking with our state housing director, or how is that we're talking with our governor's office about the need for more funding in the budget? That's translating that individual advocacy into a policy advocacy, more of a public impact. Finding residential treatment beds for clients. We know what it's like to call around, try to find a pro bono specialist, somebody who can take our uninsured guy and, hey, beg, borrow, and steal what you can because, right, people aren't insured. At the same time, when we're having public policy discussions, we're talking about the larger community capacity to have residential programs that can accept many more people, that we can have a Medicaid program that's not just, we're not just talking about, Florida and Texas that have an expanded Medicaid. People in Medicaid expansion states have got lots of folks who are either uninsured or underinsured, or the Medicaid program isn't covering medical respite services. So there's lots of ways that we can be looking toward Medicaid as an improvement. So again, that discussion is a policy discussion. When every time we're trying to find a client, because we couldn't, his encampment got swept, if we stop local encampment sweeps, again, that idea of individual to the macro. So just, again, a framework for thinking about the public policy process. And then speaking of, if we go to the next slide, thank you, Caitlin. Just also want to level set here too on a little bit of our, if we can think back to our high school civics class, 3 branches of government, 3 levels of government, right? So we've got our legislative, executive, and judicial. Each one of those have got separate responsibilities. And in particular, you cannot mix and match them, right? That's where we get in trouble. And then 3 levels of government, federal, state, and local. And federal government's going to be in charge of some things. State's going to be in charge of different things. Sometimes those things are shared, but sometimes things are very local. And so again, depending on what your problem is and depending on what solution you're pursuing, that's going to guide you to which branch of government and what level of government. And pretty soon you start looking at who's the actors that you're talking with here. I have an entire semester of a graduate program that talks about the public policy process. And this little word cloud here is basically the framework for what public policy looks like. So at its core, public policy is about solving problems. So if you have identified a problem, and we'll talk about a number of them today, All right, we've identified a problem, and once there's agreement that there is a problem, well, then what might be a solution to that problem? And often there are numerous solutions being identified, right? So then you have the cumbersome process of figuring out, well, what solution are we going to pick for right now? We move forward to try that into implementation, and then we see how it went. And then we come back to, okay, was there still a problem? What do we do this time? And so it's a constant iterative process. Where you fall in this graphic here is, again, going to depend on what branch of government you're in, the level of government you're in, and who's the person you're talking to. So if we go even to the next slide. So let's think about people and common problems, right? So let's talk about how common problems in medical respite care. Do we have an inadequate reimbursement rate? That's a problem. What if your Medicaid program doesn't cover the patients that you're seeing? That's a problem. How many services do Medicaid cover? Is there any housing available for you to discharge in? What about your skilled nursing facility that won't take somebody who's homeless? What about the increase in an unsheltered homelessness in your community and how that impacts your program and the throughput of the hospital and all the rest? What about even the existence of your program and the need for many more? So again, all of these are common problems and questions that we're asking in our community. Plus, I don't presume that this is the short list. But then when we think about who are we engaging in that discussion, right? And so this is where we come to, how are we talking with our Medicaid director? Do you have state legislators that can be champions for you here, especially on your health committees or your budget committees? Your public health authority, your housing authority, your continuum of care leadership, your mayor, local city or county council. Lots of folks have got state or local interagency councils on homelessness. And so again, there are specific people who were set up and are tasked with addressing the problems that you're having. So these are the folks that you should be having active relationship with. Let's move to the next slide, Caitlin, because I know my few minutes are up, because we're going to then plunge into some of the juicy topics where we're really going to let's get tangible about a couple of the problems that we see in medical respite, and let's walk through that. So, but just want folks to get an appreciation of where the council's public policy priorities are right now. And we try to use as guiding principles. Again, there is a lot that is involved in creating homelessness and perpetuating homelessness. There's a lot that needs to change in our country. So where do we specifically need to be in our advocacy, knowing that there's a lot of other really good advocacy going on right there out in the world? So we need to look at what's the impact of this issue on my community specifically, whether that's your medical respite program, whether it's your hospital system, or whether that's the HCH community broadly. What's the level of the broader issue in the healthcare in general, or homelessness field in general? How can we make, and again, we might be the council, we might be you and your program. How do you make a unique and value added contribution to this issue? So are you speaking to something that you are bringing to the table as an expert? And then again, the strategic value is sometimes there's folks who are advocating for an issue that you might agree with, but it may not be strategic for you to be advocating together. It might not be a partnership that works. And then again, thinking about upstream impact. We ultimately are about preventing homelessness. So it would be great to get out ahead of this stuff. And so based on these principles, these are the 4 priority areas of the council: improving our healthcare financing, advancing medical respite care, increasing access to substance use treatment with harm reduction approaches, and then collecting mortality data. So this is where the council has staked its flags based on its guiding principles on how we're integrating our service with our larger advocacy. To that end, also noting that this is a strategic plan for the council, again, in our work with the HCH community. So I think with that, Caitlin, I'm done level setting. Happy to answer any questions, but I know that we wanted to get into more of the meat of our discussion by leveraging this into a common problem that we will walk through.
Yes, thank you so much, Barbara. So this would be helpful if I shared my screen. So I'm going to welcome Kim to come on as well. So we are For those of you who've been in other conversations, you know the respite team is a big fan of Mentimeter. If you haven't used Mentimeter before, you can use your phone to scan the QR code to log in. You can also go to menti.com, and we'll put the link in the chat and enter the code that you see on your screen. And we'll give everybody a few minutes to get in, and then we'll start our participation. What I will note, just in case, we're going to present a couple of scenarios and some respite-centered what would you do's. These are sticky topics because there's very few things in medical respite that are cut and dry and pretty clear. So what I will say is these are all anonymous responses. So please feel free to kind of participate as you feel comfortable. So, but this is really just kind of learning and engagement purposes for us. Whoops. All right, give me, everyone has an extra minute to log in because I lost track of my screen that I need to control. All right, perfect. So we have a good number of folks in. The instructions to join will continue to stay at the top. So if you're kind of logging in slowly, you can join this at any point in time. So Kim, I'm going to invite you to join us and introduce our first scenario.
I think you might be on mute.
Thank you. I was saying I didn't get punched in the face by a patient, I promise. I was small skin surgery yesterday, so bear with me. Okay, so here's our example, and I'm sure that many people have seen a lot of this happen across the country. So our medical respite program recently transitioned from being in a shelter space operated by a partner into a standalone space that they fully operate. With this transition, the program has maintained the policy of not allowing clients to engage in on-site substance use, but is now more flexible if people return to the program after using substances or alcohol. Staff have had varying levels of implementation of this practice, in part because program policies and procedures are unclear about what happens if someone is found to be in possession of substances or equipment for use. After an incident where a client returned to the program while visibly under the influence, while not disruptive, it was clear that they had used, and when asked by staff, responded yes, that they had used when off-site. Staff member requested and required the person to turn over their items and collected both the substances and needles the person had on them. Staff were conflicted about this response, including the safety, legality, and potential for loss of funding and support from the neighborhood. Some staff suggested returning to the previous shelter policy of not allowing any use or intoxication of clients at the facility, while others note the importance of a more low barrier and harm reduction approach.
All right, so now is the part where you get to join in and share what should the program do as a response. You can select on whatever device you're on, select your answer here.
Do you guys, Caitlin, do you guys have audio?
Oh, you know what? That's a good. I will read the responses. Response options. Thanks, Jack. So the first option is to ban any use of intoxication on and off the premises, and possession of any substance or equipment. Those who violate the ban will be charged. So that's will be discharged. That's option 1. Response option 2 is to ban any use, intoxication, and possession on or off premises, but develop a contract for clients who violate the ban before they are discharged, sort of a second chance policy. Option 3 is to continue to allow use and visible intoxication, but require clients to dispose of substances and equipment before returning to the program. Option 4 is to continue allow use and visible intoxication, but require clients to turn in any substances to staff, and staff will dispose of it. And then the final option is continue to allow offsite and onsite visible intoxication with a don't ask, don't tell policy to not acknowledge substances or equipment if seen. All right, so I think we have a good number of responses here, and I think kind of a spread of mixes here. Sorry, word issues today, apparently. A spread of responses here, kind of a mix of responses. And I think we pose this intentionally because there's not necessarily a right or wrong answer. But what we are going to do is, while you're thinking of this answer, I'm going to let Kim share kind of a program example of how they address this within their own program.
Great, thank you. We have found that, and I think probably most people have found that things are really changing across the country with drug and alcohol use. I remember our founder, Sister Adele O'Sullivan, when we first started out in 2014, we had a patient that would go off site to a doctor's appointment and they would come back drunk. And Sister Adele, with her sweet angelic voice, will say, "Oh, Joe," or whatever his name is, "just go back to your bed and sleep it off and we'll talk about it in the morning." And obviously back then we're thinking, oh my gosh, I can't believe she's doing that. He came back drunk. And over time now, people are going to their doctor's appointments and coming back with fentanyl and sharing it with everybody at the respite center. So staff are feeling unsafe. Many are struggling. I see Sharon Pellman, one of our physical therapists, is on the chat here today, and maybe she can chime in at some point. But it's been very difficult. Some staff want to call the police when somebody comes in with fentanyl, or if we find fentanyl on site. So we've started having discussions, letting staff talk about what we're doing. I've been talking a lot to the security guards. There's one group of employees that are really struggling, and I let them know that, you know, if I wish I could call them something different than security guards, because I think they're more than that. They have to be able to like the rest of us do, meet our patients where they are. Many times they'll say, "Oh, I caught this guy with fentanyl. I'm going to write you up, or I'm going to turn you in." And so we were really trying to change that language. And I told them, I said, the last thing you want to do is shame the patient. You don't want to embarrass them. They already have a lot of shame and feel very embarrassed about what they're doing. It's a medical disease, and I was really trying to reinforce that with them. I also said, you know, obviously take the drugs from them, explain why, that we want to make sure that our staff and the other patients are safe. And you can say, "Gosh, it looks like you're having a rough time today. And there's plenty of people in this building that are here to help you." And so those are some of the things I've been trying to coach our staff on. You know, one of the security guards said, "Well, if they want to wake up every day and still do this," and I had to tell them, people aren't waking up saying, "Oh, I'm going to do fentanyl today." You know, they're doing everything they can to get that next fix. And if it was easy to quit, we wouldn't have a drug problem in the United States or in the world. So anyway, so that's how kind of we're approaching it. We're still kind of taking baby steps. I think there's quite a few people at Circle the City who know that, you know, we're meet people where they are. We want to make sure everybody's safe. And then I also talked to Sister Adele. So how do you handle this? And she says, you know, we really need to change with the times in order to fulfill our mission. And so that's the message from her for all of us.
Great, thank you, Kim. So, you know, there's a lot of, I think, policy questions that come up here, right? So it's a very practical program example. I think everybody is managing this issue in some way, shape, or form in terms of serving the folks that are served in medical respite programs. So now we're going to take this everyday practice issue and think about it from the policy perspective. And I'm going to turn it over to Barbara to help us through that.
Sure. So I see a number of you are still in the mentee space here. What are the policy issues at play in this? Again, very common issue that we have to address in the service space. So we see need for expansion of harm reduction services, both the policy and the funding, behavior management, health and safety. We can come back to that. internal space use or guest agreement. So that might be more of an internal policy that's a program policy. And then the criminalization of substance use as a public policy. And so I think all of these are totally applicable here. One of the things that I want to maybe drill down on is, so let's maybe tease through what are the problems here that policy would be addressing. So one problem is that the safety of staff and patients. That was very well timed. Safety issues. If staff aren't feeling safe, then what is it that might be done to help staff feel safer? And so one of the things that I know, and again, there's no right or wrong answer here, but possibly a blend of things. A lot of times it's because we don't have enough staff, right? And so it's if we had more, and Kim said this, well, we had more security staff. And again, we know security or more than security. The MILU management, if we had more staff that would be able to manage the environment. So a lot of this comes down to reimbursement rates. So if I had a higher reimbursement rate that covered my ability to have more staff to ensure a safe environment, maybe that would make the difference. If you could get more money to hire 1 or 2 more staff per shift, particularly in the overnight, maybe when risk was higher for overdose. So that's one thing. I want to get back to the criminalization of substance use in general. Our drug laws in this country are the ones that are specifically making us worry about the presence of drugs on site that would then jeopardize the program. If it wasn't illegal for the drugs to be on site, then you wouldn't be. So maybe there's a discussion to be had on how can the program be held harmless? How is it that you can have a discussion, perhaps with your local law enforcement? So these are some questions. I'm seeing here termination of certain funding that requires abstinence. Very good point. A lot of times our grants and our funding sources drive by the decisions that we make, and those decisions may not be what we would want on our own. Jack, I'm seeing your hand raised, so I'll ask for you to contribute.
Yeah, no, thank you. So yeah, we currently have a 16 bed medical respite program in Washington, D.C. Caitlin's been there. We're expanding to, we're doubling the size. It focuses on homeless men. We're actually now going to double it and include homeless women. So we're in the middle of a major expansion. For everyone out there, and just a footnote on what you were saying, Barbara, I mean, honestly, I gotta tell you, the legal concerns are almost zero for us unless there's true danger involved in, either the use or the behavior. The issue for us around drug use, which is not tolerated on site, but very, very openly and flexibly tolerated off site, is that the trauma-informed issues get out of control pretty quickly to the degree that you allow use on site. It's just going to spread up and down the hallways in our experience, and up and down, throughout the cohort of residents. So the issue is one for us. I just want to add just the footnote is it's not of legality, it's of remaining a safe space for actually more for residents than staff. Staff can always leave. I mean, they're not going to, but are we creating a safe space for the homeless men, all of whom are very aware of everything going on with every other resident?
Completely agreed. And I think this is the tension point, right? Because then when we have a no substance use policy, then we aren't able to serve probably a sizable portion of patients that otherwise would need our services. And so how is it that, for example, an equity issue here, if they weren't homeless, they'd be at home. And we can all do drugs in the privacy of our home without people that are not related to us having an opinion about that. So this is this is the rub of the injustice of homelessness, is that all of a sudden there's all kind of rules that people want to apply to you and your body that no one would consider putting to you or your body. And I think that's where this gets to be a sticky wicket, because no one denies that the issue is still certainly has the potential to cause problems in the program. Alexia, I'm curious what you would add to this.
Yeah, thanks so much. And what a great conversation. I'm really glad that I am able to be here today. Thank you for the opening presentation. So I did drop it into the chat, but I'm just really struck by maybe there's something for us to learn. I was thinking, I mean, safe use sites, certainly there's something for us to learn. We don't want to become safe use sites, but they are grappling with these issues, and they have been for a while now. I know New York has been running a safe use site for a while, and Washington State is also running one. Minnesota just passed in our legislation this past legislative session to fund for safe recovery sites, because they're Minnesota, we're not willing to go up against the feds, but we're willing to, so it can't be a safe use site, but a safe recovery site. And certainly they're going to be grappling with how do we, have people safely store their own belongings and come in and be safe with the staff, with the other members in these locations, and they'll probably base them out of needle exchange or something of that matter. And then, but like really thinking about, then I was thinking about wet houses, which have been around for decades. And I just wanted to point to, this is my personal experience, and so this might not be everybody's. So please forgive me if I'm stating something that triggers somebody. Wet houses were dealing with alcoholics and drinking, and now everybody uses multi-mixed drugs, toxicity and such. But for decades, it was primarily alcohol, and how they ran organizations here in Minnesota was that each individual would have a locker, and they'd have to, it was like in the entryway outside, and they'd have to store their own things there. And certainly if we're thinking about the differences for staff, alcoholism can be a very violent disease where people can be very aggressive when intoxicated. Fentanyl and opioids, where there might be a higher significant rate of overdoses, potential for overdose, certainly, but it's not usually violent in my experience. Whereas alcohol can be very violent for people engaging and trying to get people to calmly go to their room and sleep it off. So anyway, I just thought I would add that for what it's worth. And please don't think that I know everything about how people are going to respond when using substances, because I don't.
No,
So
we all are feeling our way through this every day with every client. And I appreciate your suggestion here. It's a very harm reduction focused idea to play with. Yeah. Others' thoughts on what are some of the public policy responses? Again, the program responses are one thing, but they're driven in a policy environment. What could we do to address this issue better? I like the idea of, I've always been intrigued by safe use spaces, medical respite in particular, because cellulitis and wound care and some of the things that are so prevalent with injection drug use are also some of the medical conditions that we are very skilled at treating. And so I'm thinking through do we start co-locating, even if it's not run by the same places? But I'm coming back to Sister Adele, Kim, in that we have to start doing something different to keep up with how people present. And so maybe those are the partnerships that we could be looking at. How do we maintain? And I also think it's a question too, is it the behavior that we're responding to, or is it just specifically the de facto drug use? And so that's also, again, a very programmatic milieu management issue. But when we think about drug laws, when we think about the operating, even the ability of our program to operate, what's our admission criteria is going to be driven by the kinds of staff and services. That's driven by our reimbursement rate, and that's driven often by the grant, Medicaid, things like that. Laurel, thoughts on this?
So we pretty much follow what everybody else indicated, that we permit usage, but not on site. And we'll manage through that with case management. But I think that the bigger problem and the scary thing for us is the fact that in Ohio and Cincinnati, or just for us specifically, because I know the other agencies in Ohio don't face the same situation, but we're also at the mercy of being licensed by the state of Ohio. So there's a whole nother set of regulations that we're kind of flying in the face of at this point, because we're honoring how we feel, saying that usage is going to happen, but we don't allow it on site, and we're going to manage through it with case management and discussions and the case plan and working through that. I think that really it would be way out there, and a big goal, but long-term goal would be that maybe federally, this is how medical respites operate, and this is what they allow, and how they're going to approach treatment, versus us all having to fit into these other little silos within our states or even in our communities following those rules. I think it's a bigger discussion on standardizing the method of care that we're providing, and it's recognized.
Completely appreciate that. I think this whole discussion is really about drugs in our society and how we respond to this. And I think there's a lot that we can talk about here, but in the interest of time, let's move on to another scenario that we commonly address and talk about the policy implications to this one. So Caitlin, how about you pull up number 2?
Perfect. And this is up real quick, just in case anybody closed theirs out. We're going to follow the same process of reading a scenario and then answering a question. And it is equally, I think, as gray and not at all clear cut. So really excited about this. So I'm going to give folks just a minute to scan themselves in. And then once again, the instructions will also stay up at the top. So, all right, Lori, I'm going to invite you to present our next discussion here, maybe. All right, there we go.
Great, thanks, Caitlin. Elena, she, her, was referred to a medical respite program from the local hospital, which is the program's primary referral source and funder. Elena was referred after fracturing her wrist and bruising her hip in a fall. This will allow additional time to heal and to participate in PT. She also has a history of a stroke and is diagnosed with PTSD, anxiety, and borderline personality disorder. Once the medical respite program, Elena presented with needing a higher level of support for ADLs than is provided within the program. Staff are managing Elena's needs the best that they can, but staff have varying levels of confidence and feelings of being equipped to support her. Some staff are also becoming frustrated, as she also frequently seeks out staff for support for ADL needs, some of which staff believe she is able to manage independently. After 10 days, Elena sustains a fall while using the bathroom. Although she did not sustain significant injury, this incident triggered several staff to express that Elena is not appropriate for the program. However, other staff feel like she should stay in medical respite until she can get into a skilled nursing facility. Case managers have been contacting area SNFs for admission, but have not yet found one willing to admit her. They have also not been able to access in-home support services, which would be home or community-based services, to provide ADL supports either. What should the program do as a response? And so I'll read these because I know some people can't see the screen. So here are our choices. Return Elena to the hospital via the emergency room. Discharge Elena from the program with the option to move into a shelter. Or third, Keep Elena in the program until a SNF bed is available.
A little
lot
more consistent this time around. When Barbara and I were putting these together, we were talking about like, here are the options, and none of these are the best option, right? Because the best option would be people getting the services they need at the right time, which is not what is happening here. So I'm gonna, Jack, hold your thought for a second here, because we're gonna turn it over to Lori just to kind of share her example and program about how they addressed it. But then, yeah, we'll be jumping into discussion around this.
So yesterday we used this as a case study with my management team because I wanted their input on what we would do. And I will say this is a pretty common occurrence. So there are two parts to my answer. The first is Elena's already with us. So I'm going to address how we would manage her case at that point. But then I'm also going to talk about what we would have done prior to Elena coming. So we side with everyone else. We would keep Elena in the medical respite program. But the biggest pieces that we would alter or change with her case would be instructing our staff to have a little more interaction with Elena. So talking about medical staff, that we're checking with her more frequently and that we are keeping a closer eye on her, making better observations about where she is moving around the building, where she is in her room, how she is navigating around the facility, and just keeping a closer eye on her, but assuring staff, because they have a right to be nervous about this, because of course they care about our clients and they do not want anyone to struggle or get hurt. But reassuring them that we're moving as quickly as we can to make other arrangements, which is the other piece that we would work really hard on. Secondly, there would be a change in her case management. So we would, as part of the individualized case plan, maybe Elena's original housing plan would have been for her own apartment. We would probably start talking to Elena about maybe other options that provide more support, specifically talking to her about maybe going to skilled care, even if it's temporary, until she can get some PT to help her become more stable, or maybe it would be permanently at an assisted living facility. So we encounter this frequently, and that is pretty much how we proceed. So we're giving her extra attention. I think also part of her case management would be talking to her about where she is requesting additional needs for assistance with her ADLs that we believe maybe she has the capability of completing for herself. And through case management, maybe talking about those capabilities and supporting her and saying, you really can do this. What can we do to help you feel more comfortable performing these things for yourself? So that would all be part of the case management. During our little discussion with management yesterday, presenting this case study, one of the things we talked about is all of the things over all of these years that we've put in place to avoid this situation. Now, I'm not saying we're perfect or we know how to avoid it, but we've put a lot of things in place to try to prevent these types of situations. So some of the things we talked about were when we have a client, especially with a history of stroke, because that is usually an indicator, we are trying to visit that individual while they're still in the hospital so that we can kind of gauge their capabilities. So, you know, we're visiting, having a conversation, observing for independence and ADLs that will help us make the best decision for admission. Because if this person is truly beyond our scope of care, our level of care, we may have to make a different decision about admission. And, you know, trying to really do our due diligence prior to admission to avoid what we, you know, I think everybody sort of refers to as the dump, because we are going to encounter clients where we're not going to get the full picture as hard as we try. And they're going to come in and maybe not be appropriate for our program. So, you know, we've spent a lot of time trying to prevent these things from happening. They still happen, but it is really becomes a priority for the medical staff and for the case management staff to get this person, keep them safe while they're with us, but to get them where they need to be as quickly as possible. Some of the things we've done, we've established a very strong partnership with our Council on Aging, who is very quick to come to us because now they trust that we're not calling them for an assessment for level of care unless we're really sure we've got an issue. So they trust us now, and they're very responsive with helping us get level of care determined so that we have a more efficient inroad to maybe a SNF or an assisted living facility.
Great, thank you so much, Lori. So I think that's an excellent example. And now I'm going to turn it over to Barbara because we have some really great discussion points on policy here. And I know a few other folks had things to say. So Barbara, take it away.
And Jack, I haven't forgotten about you. You're first on deck. Mostly just wanted to also acknowledge really great responses here. The SNF refusing to take homeless folks is a key policy issue. Like that should not be allowed. And that's directly connected to other more funding for housing. So SNFs can accept patients without homes, knowing they'll be able to exit them. Looking at the policies to address improved reimbursement rates for SNFs. Maybe, again, we would appreciate risk-adjusted reimbursement rates. I'm sure SNFs would also appreciate a risk-adjusted reimbursement rate because some more vulnerable folks that go to SNFs do need more care. So how do we acknowledge that? Again, and we can talk about, and we have not yet, but the fundamental broken nature of the American healthcare system in general, right? So all of this is driven by your reimbursement rate, and a lot of the facilities that we're going into are for-profit facilities. And so again, these are the kinds of the ability to pay drives your access to care in much of this country. So all of that is policy issue. And then I'm just looking at these licensing accrediting issues for medical respite programs. Those are clearly policy issues. Accommodations, modifications, and care, more of a program issue, but having a reimbursement rate that gives you staff to be able to do that, I think more drives that policy issue. And then, yeah, just what again are the ability of the community to meet Elena's needs. So really appreciate these contributions here. Jack, you tried to wave me off, but want to still give you an opportunity to weigh in if you had something to put in here.
No, I mean, I'll just be the meanie in the room. I mean, yeah, I did not, I definitely didn't check off, you know, an emergency room back to hospital, no emergency. There would be an emergency room in DC would have turned her back to us in about 1 hour. I can't remember the third option. There were no good options on this one. And what we've really done, I guess what in our rep, and we will continue to do, is we really, I don't want to sound non-low barrier because we really are low barrier, but that front door can be very important. And if you're not careful, you will turn into a SNF yourself. You know, there will be people, and as a clinical social worker, you know, although I do know Elena, I think, based on what I just read, and Elena may be, given the constraints around resources and abilities of places such as SNFs or hospitals, all of whom are talking to one another, you know, to adequately respond to someone like Elena, I mean, is systemically it's limited. And so the spot that takes her and decides, you know, we're going to work with this situation, which is Elena, maybe working with her for a long time. We on more than one occasion have kept people, even though our funding from our MCO partners is technically no more than 5 months. We've kept a few folks more than a year because of this very situation. And it's from a revenue standpoint, it's a problem.
And I think you've clued into a couple of policy issues there. It's about
I know I did.
Nope,
I
nope, thank
structured it
you.
to give you the,
set me
you
up
know.
perfectly for that. Also thinking about it, and I'll just come back to our previous exchange, Jack, too, is let's think about if Elena wasn't poor, how would all of the options be different? If Elena had tons of money, then Elena would be in assisted living that she was paying probably $2,000 or more a month. Elena might have all the personal care that she needed. So a lot of this comes down to how much money do you have to be able to pay for the care you need? And if you don't have the money to pay for the care you need, then you're at the mercy of whatever your community is going to be able to cobble together. And a lot of communities can't do it. And we've all grappled with none of these solutions works well for Elena. And I think that's where we come back to is we've got a healthcare system that does not allow us to meet the needs of our patients, no matter how well we put our programs together, because there's this larger continuum of policies that inform and that frankly influence who comes into our program, the care that we're able to provide while they're there, and the ability to exit them from our program. And so all of this is informed by this broader environment. That's why it's so important for us to, yes, have these program conversations, but also think about how are we stepping into broader solutions with the policymakers who are in charge of that larger environment. Want to also give a shout out here to comment from Sharon in the chat. Circle City is unique in having PT on site. So Caitlin was an OT for us in Baltimore HCH, and I just remember how thrilled we were when we were able to up our game with being able to offer your services. And since we've been able to offer a lot more in that regard, but again, it comes down to the ability to pay for staff who bring those skills. But agree that that's key for safety assessment, staff education, and being able to meet more of the needs of people like Elena. Other contributions, other ideas for where we're seeing policy issues inform Elena's care or inform our ability at the medical respite program to respond to that. And I know we just have a few minutes left, Caitlin, so I see you putting some resources in the chat here as well. One of the things that comes to my mind too is your medical respite care is one program, but we've often talked about needing different kinds of programs for different kinds of needs. So do we have larger programs that include step down areas? Do we have multiple programs in a community that can meet multiple levels of need? These are questions. But again, even the ability to have a medical respite program is in and of itself a policy issue. Laurel.
So it's interesting. I find this interesting because I had a conversation yesterday. So state of Ohio, the medical respites were kind of joining forces to try to force our MCOs to get on board with us. And part of that discussion, it brought up a very interesting point that I think is related to policy, because a representative from CareSource indicated that, well, he was actually in Indiana and was on the board of a medical respite in Indiana that only has 12 beds. And he indicated that there wasn't a lot of interest from those MCOs to invest any time or resources into that medical respite because it was so small and it wasn't going to provide for enough of their members for it to be worth their time. And what I said to him was, well, you need to support us because the only way we can get bigger and provide more services is if you fund us. So, it's this round and round and round conversation that we're having that, we're hamstrung because you can't or won't support us, even though it's probably to your benefit and to your members' benefits, because we're small. But if you fund us appropriately, we could be much bigger and provide more services to your benefit. To your members. So I think that is a policy issue, and it ties right into that, Barbara, because, maybe we need specialty care within medical respite, but you've got to be able to afford to do it.
Well said. I am conscious of our time, so I just want to leave us with this, that I just hope that our conversation today has just illustrated how important it is for us to be involved in public policy discussions. They're so directly relevant to the care that we're able to provide. So talk with folks, find your champions, be part of the conversation, pursue bigger solutions. This is about more than just an individual program. This is about the community of care that we're able to provide. And there's so many people who are policymakers in this space, but they need you at the table and they need your partnership as well in order to move forward. So I'll just end with, everybody needs a navigator. Find yours in the public policy space, make best friends, do good things. I'll turn it over to you, Caitlin.
Great. Thank you so much, Barbara, for joining us and for facilitating our discussion today. And thanks to Kim and Lori as well for being willing to share kind of how your programs have tackled some of these. And of course, all of you for participating and kind of sharing your thoughts through Mentimeter as well. So just a couple of quick wrap up points. The slide deck was shared in the chat today, so you're welcome to download that as reference. And it also includes all of these resources that Barbara put together around advocacy and recent policy publications. And then the last thing, speaking of MCOs, I didn't pay Lori to promote this, but this was really helpful. We have 2 webinars coming up in October focused on financial sustainability of medical respite programs. The first one is on general strategies and recommendations, and the second is specifically focused on partnering with managed care organizations. These are going to be presented in partnership with Quantified Ventures. So the registration links are in the chat, and I think maybe in the PowerPoint as well. If not, you can find them on our website. So again, thank you, everybody. We're right at the hour. We hope to see you at these webinars next month, in addition to any of our upcoming activities. Have a great rest of your Wednesday. Thanks, everyone.